Good evening, everyone. So I think we have representation from all the institutes that actually do the training, so it's really nice to see today. My slides. So I'm going to be talking about surgical skill
Could we
enhancement.
have the slides?
One second. Okay. Okay, so for pediatric ophthalmology and neuro-ophthalmology. Okay, so the earlier Halstead traditional teaching was to see one, do one, and teach one. So this was the earlier model where we didn't have a really objective way of teaching surgery. So it used to be like the surgeon decides how well the student does, and then they teach, and then they ask them to teach further. So that's how it was earlier, and I think we've digressed a lot from then. Now it's more objective, it's more structured, and it's more towards patient outcomes. And as a result of which, whether knowingly or unknowingly, there has been a downward trend in the amount of squint surgeries that we're actually giving our trainees. It's down from 121 to an average of 43. So this is something that actually has an impact on how the residents feel when they take up pediatric ophthalmology. So this is another interesting article where they acknowledge the absence of structured surgical training and pediatric posting during the residency program itself. So that sets them up for taking pediatric ophthalmology as a career. So it is very important that against this background, we give a good amount of surgical exposure in a very structured manner that gives good patient outcomes as well as good exposure to the trainee as well. So before we begin, we really need to understand and also be ready as a trainer to be to exude confidence, and that's within double quotes, because though we might be laughing outside, it's as a trainer, we know that during surgery, there are so many situations where we are kind of going to be really putting our emotions back and trying to adjust to what is happening there with the trainee. So definitely putting a bold face up is a big thing. Second thing is to allow mistakes to happen, and that's again to go back to our fellowship days as how we were as a fellow, and then to learn from that and allow the trainee to make a mistake and then to learn from that. The third is to be generous and to give a lot of exposure to the trainee in order to learn, including complex cases. The next point is about being fair, which basically means being fair both to the patient as well as to the trainee, because there are some trainees who can be quick on the pickup, and there can be some trainees who can be a little, they can take a little time to train. So in those cases, we'll have to make sure that objectively both get equal good amount of exposure, as well as not compromising on the patient outcomes. And always ensure that you have a good team backup, and that's the secret behind a confident trainer. When you have a good VR backup and you have a good team behind us, and then we have more confidence in training our fellows. So surgical training basically begins in the OPD. So always good evaluation techniques have to be taught in the OPD, and always sticking to protocols, especially when they are getting trained. So 9-gaze measurements is a must, sensory evaluation is a must, doing documentation with photographs is a must. These are basic things that if they don't learn there, they're never going to learn it outside. And of course, learning the concerned diagnostics and the way of arriving at the diagnosis is also something that has to be taught to them way before surgery starts. And final plan of the surgery has to be discussed with the trainee, and optimizing surgery. And by optimizing, I mean if there is to analyze the situation as a whole, the diagnosis as a whole. And if there is something where you can add a component to optimize the surgery, then definitely it should be done. And that should also be discussed with the fellow before going in for surgery. Now, once the OPD is set, then the fellow has to go into a good orientation. So a knowledge enhancement is definitely a part of surgery skill. So they have to know their surgical anatomies, they'll have to know their instruments, they'll have to know surgical steps and the possible complications and the outcomes that can come out of it. So usually before surgery starts, they'll have to end up having a good theory knowledge on it, and usually before surgery, it's advisable to go for one viva on a one-on-one before they start the surgery procedure, so that they know their theory. And When it comes to wet lab practice, does it really help? Yes, because surgery is basically skill. It's a muscle memory. The more the hands work on it, the more the hands get acclimatized to good surgery. So wet labs definitely help, but how does it help, and how can we help it in strabismus? So there are many simulated models available. These are some models which are non-biologic models, but they are a little expensive. We do also have another one that was recently introduced in WSPOS last time, and we had a hands-on experience on these models, and these were good as well. This was another interesting low-cost technique from Dr. Pujari, Amar Pujari, and you can see that these goat's eyes were used to train for recession and resection, and it worked pretty much similar to the human eyes. So this is another interesting technique. Another one that was recently that I came across is a very simple but very effective technique to teach strabismus surgery before the real thing. So here they use a simple tennis ball, a ping pong ball, and then you put it on a wooden board, and then for the sclera they use foam boards so that it mimics a sclera, and for the muscle they use felt. So it acts similar to the muscle texture. So here you can see this is how they place it. The foam can be placed in 4 strips, in 2 strips across, and the felt can be placed as 4 strips. The good thing about this is that it actually mimics the kind of texture that we're looking at, but the downside to it is you don't get a exposure thing like the tenons, how you dissect. Those are the things that you'll probably not get a good idea of in these models. However, there have been studies that have been done on bacon. So they say that testing it with bacon gives a little more of a tissue separation experience. So these are all low-cost models that can be done. This is another model wherein they used a rubber ball to mimic the sclera, and gloves to mimic the conjunctiva, so just simple latex gloves that can be stuck all around. And also the white bands that you see are the muscles, which are nothing but elastic bands, and they found that to be something similar to the recti muscles. So again, this gives us a good sense of feeling and muscle memory that helps them in training. So these kind of wet lab workshops kind of really help and go a long way in setting up the trainee or the fellow to actual surgery. So before surgery, of course, measurements have to be recorded, photos have to be documented, and the final plan has to be decided before going ahead. So this is just, I pulled out stuff from my logbook from way back, and you can see that the day before the surgery, the trainer or the trainee or the fellow has to sit down and write the entire plan for all the surgeries that to be done the next day. And this is really important because the fellow actually gets to learn what is going to be done, and then that sets them up mentally for what's going to happen the next day. So on in the OT, on the initial observation, the day 1 would probably be just a flow observation, just to see how the flow, the OT flow happens. From day 2, I think it's always good to start, for them to start assisting, and first as a second assistant and then as a first assistant. They should know the instruments, handling of the instruments, and how each goes and in which order. During surgery, of course, before they actually start on the patient, they need to be primed. So we need to tell them that you have to stop when the trainer tells you to stop, and you need to listen to the trainer as you operate. And these are basic instructions that have to be given before any surgery starts. And next thing is, there are 2 ways of doing it, step by step or going entire surgery at one go. So we always prefer the step by step because they get better at one step, we give them the next step. That it gives them more confidence. We usually start with the conjunctiva, the hooking of the muscle, and of course conjunctival closure, and then slowly as they keep getting better, we can give them muscle tagging, and then finally the scleral bite. And initially it's always good to stay with the fellow completely, and then as time passes by, we can let them do the surgery on their own and then just pop in for the scleral bite alone. Post-surgery, it's really important to do a thorough follow-up. The fellow has to come, remove the patch, do the dressing and see what the outcomes are, and also do the logbook entry. That helps them complete the loop and to see how the change has happened. And then it's also good for them to discuss with the juniors, and that helps them refurbish in their mind and also pass on the information to the next set of students. So this is the ICO Oscar grading for strabismus. It's really, it's an excellent tool for objectively grading surgery outcomes. We can see how each step has grading from based on the Dreyfus model, the novice, beginner, advanced beginner, and the competent. And then as the trainee advances, you can score them better so that they know how well they're doing. Of course, when you comes to complications, you can't avoid this, globe perfs, under overcorrections, anything can happen. But as a trainer, we'll need to step back and help them do it. So we need to maintain that British stiff upper lip when it comes to dealing with these complications and not show it to the trainee and also manage it on the patient side. So definitely advanced strabismus techniques have to be taught to the trainee. Oblique muscle surgeries are definitely, they've become commonplace now. Transposition surgeries as well. And definitely, if not directly operating, at least they can assist complex strabismus syndromes, nystagmus surgeries, and at least a few resurgeries as well. Exposure in these arenas would really help the fellow. When it comes to pediatric cataract, it's very important that the trainee has prior adult cataract surgical experience. That goes a long way for them to, in terms of their hands. So what is recommended is around at least 100 to 200 SICS and maybe around 50 phaco's. That would give them good hands. IOL power calculation has to be taken, and again a viva. It's always good to start with older children initially, maybe 6 or 7 years and above, and then go to younger children. Initially LA plus PCIOL, and then followed by anterior vitrectomy and PPC. And it's always again good to give steps very slowly during the initial parts and then take them forward on the advanced steps later. Again, this is another ICO scoring for the pediatric cataract Oscar grading. Again, very detailed. I think this was developed in SN. So the question, how many surgeries can a fellowship provide for surgical competency? There's really no golden number to this, but on an average, about 30 to 40 strabismus surgeries or around 20 to 30 cataract surgeries would probably form a good exposure to the trainee. And of course, neuro-ophthalmology exposure, posting with the neuro-ophthalmology department, and also discussion with the radiologist. This is another thing that we tend to emphasize. They travel to the radiologist and discuss the scans with them. So that really helps. And another thing that I wanted to add was the post-fellowship services that we can extend to the fellows. That is, one is library services. I think Arvind already extends it. If you're an alumni, you get access to their library with a basic minimal fee. The second is long distance mentorship. So maybe after they leave, the first 10 or 20 cases can be mentored long distance, and that would really help them gain confidence. And the third is, of course, collaborations. Once an alumni, always an alumni. So you get to collaborate with them on multicentric studies. Really, the possibilities are endless. So obviously, a structured surgical program is the way to go. Give them good theory, viva, wet lab, logbook, and structured number of cases. So if you're looking to have confident, competent, thorough, and fellows with a sense of adventure, we need to set the basics, enhance the skill set, slowly initiate them into surgery, and follow them through. Thank you so much for the opportunity.
Thank you, Dr. Shruti. An excellent presentation. Thank you very much. Any comments while I request Dr. Jyoti to come and give a talk on academic equivalent going forward? Yeah.
What do you think about wet lab for strabismus?
So, of course, with Dr. Amar, we had developed this Goatseye thing during the COVID period. And all our residents now, for Squint, all of them have to mandatorily do a fair amount of, these surgeries on the Goatseye before we allow them to operate on the patients. I mean, of course, this is a rule that we have done. We had for cataract for a fairly long period of time. They were assessed, they were scored and marked, and only subsequent to their passing a particular score are they allowed to do cataract surgeries on human eyes. The same, although there is no clear scoring as such, but we kind of directly observe them on their surgical skills on Goatseye before we allow them on patients. Absolutely. Very, 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 very beneficial.
So how maybe we should approach you and...
No, it's no need to approach us. It's a very simple set. There's nothing really complicated about this. We just get whole globes of goat eyes without them cutting the muscles. So when they're enucleating the globe, they usually were cutting the muscles. We just ask them that they use the enucleation, the spoon, and we cut them at the optic nerve and we remove them with the muscles. So, and then there's just a small contraption. We use rubber bands, kind of bands to, kind of tie the muscles posteriorly onto a clip so that there is an adequate stretch on them. And then the eyes are fixed so that they can operate on the muscles and get an adequate tension to pass sutures, cut, recess, resect, plicate. They even get an idea how to do transposition, things like that. But of course, it really is not so much as far as the surgical learning there is concerned, but yes, they learn very nicely how to handle tissue and pass sutures. That's what we realized. In fact, that's what we started in COVID times, because no squint surgeries were going on at that time.
Exactly.
So it was very difficult to keep them trained.
Because
So
squints is seasonal, so
Yeah.
we don't, some batch doesn't get the same exposure as other batch.
true. So in fact, that's why we had evolved this technique, and all our residents, we have of course senior residents. All senior residents found that very useful. In fact, we are encouraging many junior residents who often do not want to continue a senior residency or want to go and do fellowship, are interested in pediatric ophthalmology. We encourage them to give it a shot as a junior resident. It really doesn't take anything but a little